Top Med Talk.
Well, hello and welcome to Top Med Talk. We are here in Dingle, Ireland for the Dingle Conference for EBPOM, or Evidence-Based Perioperative Medicine. I'm Desiree, Chappell, your host. I'm joined by Saul Aronson, my co-host and partner in crime today. Hello, Saul.
Hello, Desiree. So good to see you.
We're here in beautiful Dingle. If you don't know about the conference, it's been going on now for about 26 years, and it's phenomenal. You should look it up on EBPOM. Top Med Talk is the broadcasting arm of EBPOM, or Evidence-Based Perioperative Medicine, and we've been here now, I think, the last 7 years.
Great conference, very informative, lots of information, and a good time.
Yes, absolutely great time. So, Saul, one of the great things while we're here at the conference is we get to catch up with some of our amazing faculty. And our next guest is Dr. Alex Mittnacht. Alex, you gave a wonderful presentation this morning for us, which we'll talk a little bit about, but we want to hear a little bit more about your background. So why don't you tell us a little bit about yourself, your practice, where you live, all those good things?
Yeah, sure. I live in Manhattan with my wonderful wife and 3 children. For the last 25 years almost, I came a few days before September 11, which always raises some eyebrows, but I landed in New York, did a fellowship, never planned to stay. And, that's history by now, and I live very happily there. I'm a pediatric and adult cardiac anesthesiologist, almost exclusively practice cardiac anesthesia for both children and adults. I also have some administrative duties nowadays. I'm the vice chair of the department, but I'm very happy to still practice clinical medicine, which I really enjoy, especially for this very vulnerable patient population.
So I'm going to jump right in. Pediatric cardiac anesthesiology. Is that a specialty of pediatric anesthesiology or cardiac anesthesiology?
It's a little interesting because the specialty definitely has evolved. So when Saul trained, which was a few years before me, and then I trained.
I was much taller and thinner.
Yes. Let's put it this way. Anesthesiologists taking care of children with congenital heart disease used to often be recruited from the adult cardiac anesthesiology pool, and the subspecialty probably it's been around for much longer, and you know that better than I do. Then there was a shift, and I lived through that time, but it probably happened a little bit silently that, nowadays the majority of pediatric cardiac anesthesiologists are recruited from the pediatric anesthesia subspecialty. And large freestanding pediatric hospitals, you're not only caring for patients with congenital heart disease. If you are hired by a pediatric hospital, they often also want you to cover for other cases than just cardiac cases. So if you're not pediatric trained, that may be one of the hurdles. The majority right now in the United States, at least, of pediatric cardiac anesthesiologists are pediatric trained with some additional training. We can talk about the training requirements in a second.
You spoke of the majority, a large preponderance of congenital cardiac surgery being done in pediatric hospitals. How prevalent is that if you look at the gamut across the states? What can we think about with respect to the probability of a non-pediatric designated hospital doing congenital cardiac surgery?
So there's a large, obviously, medical centers, specific like, children hospitals, if you will. But the way billing works in the United States, if you offer a pediatric cardiac program, that it changes the way CMS, that you can bill for the whole other cases for the hospital. So as you know, a lot of smaller programs exist. We have some of the big major centers in the United States. A good mid-sized program would have maybe 500 to 600 cases, but it's not like there's a center in the United States that does 10,000 or 5,000 cases. A smaller program would be around 100 to 200 cases. A mid-sized program, probably like 300-400 cases. But there are a lot of smaller programs that for many reasons still try to keep these programs alive. And what are the chances that you have a non-pediatric cardiac trained person taking care of those patients? I think still for a real bypass case, a congenital bypass case, a neonate, a transposition, any of those cases, Norwoods, I cannot imagine that a non-pediatric cardiac trained person would be taking care of those children. I think it gets way more tricky when we talk about non-cardiac cases. It's the child who falls off the bike and breaks an arm who has congenital heart disease and now shows up in a small hospital somewhere in remote areas without even a pediatric anesthesiologist. When we write these guidelines nowadays, and I wasn't part of it, but when our colleagues write these guidelines and recommendations, they often write from the perspective of one of those large major centers, which doesn't really account for maybe even the majority of the population, for example, the United States.
That's a great point. I'm Really glad you brought that up. Backing up now to your point about training and education, can a resident who wants to subspecialize in cardiac congenital anesthesia be trained in any other environment beyond a pediatric hospital, just because of the numbers that one would ideally want to call themselves competent or skilled?
Since 2022, believe, don't quote me exactly, but I believe that's the year, Pediatric Cardiac Anesthesia is an ACGME accredited fellowship. Obviously, training started before that. And the folks who wrote the papers to lay out how training should look like, at least in the United States, they acknowledged what we just talked about. They wanted to capture the whole landscape of practicing physicians, including myself. I did an adult cardiac fellowship and then did another half year of pediatric cardiac training alongside, or after my adult training, if you will. And so they wanted to capture the whole pool of physicians practicing in that specialty. The different training pathways are that you can do an adult cardiac fellowship or a pediatric fellowship for 1 year. And you would have to do another half year of pediatric cardiac. So that gives you 1.5 year training. Most places now, the big centers probably would offer a 2-year pathway. They try to sign up residents who are interested even before they start their pediatric fellowship and say, we offer a 2-year commitment where you do 1 year pediatric, 1 year pediatric cardiac. Residents right for nowadays. The landscape right now is an overall workforce shortage. The salaries are challenging to convince a resident coming right out of training to do additional fellowship trainings.
Thank you for a great point. To speak to that, backing up in the context of the patient with congenital heart disease who may or may not have had that repaired once upon a time in the early stages of life, who now presents to a community hospital or a non-pediatric hospital because of some other surgical needs. Who takes care of that patient with respect to workforce? And if you could also interject in your answer, how many pediatric cardiac anesthesiologists exist today?
There's a nice publication which shows the map of the United States where pediatric anesthesiologists are centered by sheer number, and it's very interesting. Obviously you have East, West Coast, and you have a couple of dots in the middle, but there's large parts of the United States where you don't even find a pediatric anesthesiologist. Back to your question, who takes care of these children or anybody even with adult congenital heart disease as they grow up and present to an outside hospital? It's anybody who is available. The recommendations go that in more complex congenital heart disease, it should be someone at least understanding the physiology. But it's all recommendations. Ultimately, if you show up at one of these clinics and they do the first screening and you have something, it's a challenge. There's a discrepancy between the guidelines and what would be considered optimal care, what is really real life. If you fall off the bike in New York City, you have a choice of hospitals, but that's not the same maybe on the countryside somewhere in Montana or...
Emergencies and urgencies are dealt with emergently and urgently. But for the elective non-cardiac surgery, in the patient who is a congenital, has a congenital disease, should we be referring those patients out of community centers?
That's certainly what the recommendations say. And there's actually also nice publications showing how far patients drive to the nearest specialty clinic. And it's significant distances. I would recommend doing so. We saw earlier in our presentations today that multidisciplinary care is very important. If you have mild congenital heart disease, even in the adult spectrum, it doesn't really matter that much. But if you have a single ventricle, any residual shunts, any kind of pulmonary hypertension, you probably have a much higher risk of adverse events or not good outcomes. It depends. If you broke a bone and they just put a cast on you versus if you needed some major surgery, obviously makes a big difference.
Desiree?
We see a lot of pediatric congenital heart, and we're saving a lot more of those kids. So we're seeing a lot of adult congenital hearts. Can you talk a little bit to that? Because I know those are some of the cases that are also showing up in community facilities where we're not necessarily prepared for that.
Yeah, definitely. Numbers are increasing and the statistics are pretty clear, and hospitals try to make a little gain of that. So some of the big centers in the country actually building adult congenital heart disease centers, even like whole buildings that are dedicated to that. There's dedicated staff for that, even people who specialize in adult congenital heart disease, surgeons as well as anesthesia and cardiologists. That's because there is better survival, improved outcomes overall over the last 20, 30 years. That generation that otherwise would have naturally died earlier from congenital heart disease are now surviving into adulthood. I mean, that's pretty clear and easy to explain. So increase in demand. Are we able to meet that demand? There's very few centers who probably can survive just on adult congenital heart disease. So yes, your adult congenital heart disease patient may show up at your door at a non-specialized center. It becomes individualized. Some hospitals draw a clear line at 18 years of age. Others say they care for patients throughout their adult life because they have congenital heart disease. In most centers, especially freestanding children's hospitals, there's a cutoff age where they refer to the adult side at some point. And that transition may be psychologically stressful for patients because they were used to seeing someone since they were young, and all of a sudden they have to go and see an adult cardiologist or so on. Yeah.
What does that mean for clinicians, for us non-pediatric or cardiac anesthesia trained folks?
I find that the majority of people faced with that feel very stressed. We get phone calls from colleagues who are clearly, I think the sheer word congenital heart disease, sort of fear. I get the same, I can understand, I can relate. I don't know if there's a good answer to that other than hopefully you work at a big enough center that you find a colleague who has some experience. The other thing is about our adult trained colleagues, including myself. It's an adult cardiac anesthesia fellowship. They may have a rotation in congenital. They may have a 2-week or a 4-week rotation in congenital heart disease. It's an adult fellowship, so they couldn't take care of children with congenital heart disease, yet there's more of them than pediatric cardiac anesthesiologists. So if you work at a place where there is adult cardiac surgery and you have someone who is adult cardiac trained, who is the closest person with expertise taking care of those patients? And that's what I always tell the fellows. Like, who do you think is going to take care of the Fontaine who's coming now for some abdominal, procedure? It's not going to be the generalist. It's going to be you. And they're like, but I didn't sign up for congenital heart disease. I'm like, well, that's not the point, but it has cardiac in it and you are a cardiac trained person. So back to your question, I say if the hospital has a cardiac program, but not pediatric, probably a lot of the adult trained people should at least have some knowledge about it. If you're lucky enough and you show up at the pediatric hospital, then there should be a subspecialist available with some experience.
Just to reflect on presentations we saw earlier in this conference this year on obstetric patients with cardiac disease, and that would be a case that would be referred to a cardiac anesthesiologist. Obviously, they're bigger. It's easier to get an IV in them. It speaks to the foundational commonality of cardiac being the principal driver.
Yeah, they want to put a TE probe in.
That's right. You mentioned earlier that it was tough to get our new wave of residents to even be interested in spending the time and going down the long journey of training for congenital cardiac anesthesia. There's a supply-demand crisis of anesthesiologists in the U.S. for sure today. How do we address specifically the cardiac pediatric gap in supply-demand?
So I think you're retired. You want if you have the answer, please come back.
By the way, happily retire.
Yeah, it's really difficult right now. I can tell you that right now, and I'm sure people know the exact numbers, but I believe there is something like 20 plus training programs in the United States, but we're only producing about 16 or 17 pediatric cardiac anesthesiologists per year. The predicted need is over 120 for the next 5 years, and then even more so going down the line. At this point, I can tell you how desperate the pediatric fellowships don't even fill. Almost 40% of pediatric fellowship slots do not fill. There's a couple of recent surveys actually sent out to faculty and residents and people who are in training. And they point to a lot of different things. First of all, people in the United States come out of medical school with huge amounts of debt. The salaries for a general practitioner who can go out and do locums work or whatever is through the roof. So they really question the additional 1 or 2 years of extra training. As people value work-life balance more, they question the extra stress. What becomes apparent throughout the surveys is that taking care of neonatal patients, even people who do this for a living, including myself, and everybody has a different personality. I personally don't feel like it's stressed out. It's impossible to say your heart rate is not a little higher if you take care of an overweight patient, but it is about 30% or over 30%, it was slightly over 30% of practicing pediatric cardiac anesthesiologists are thinking about leaving the specialty for the high stress that they feel. So what are we doing about the workforce? You need to recruit, which is interesting in this day and time right now in the United States, giving the high salaries without subspecialty training. You need to retain them. So how do you retain somebody if your overall workforce supply is down, you can barely give someone a non-clinical day. Most of these surgeries are done in academic centers, and people rightfully say, well, I work in an academic center, I want to be promoted, become a professor at some point, you're not giving me any non-clinical day. It's not only difficult to convince somebody to do extra 2 years training, it's a higher stressful job. And then in order to retain those faculty, you need to mentor them, you need to send them to meetings, you need to give opportunities, which are rare in days when everybody else works overtime, is mandated to stay at longer hours and so forth. And then you have the existing workforce who really use the buzzword burnout and say, I've been doing this for quite a while and maybe I just want to... I've friends who told me a couple of days a week I do non-cardiac, and you know what? I started liking it. I feel like I haven't done a case where I just do a mask induction and put an IV in. It's so much less stressful. But there's no good solution to it. I think that we raised the bar more and more. We raised the bar in terms of who we require to take care of those vulnerable patients. And we didn't really think what would happen down the line with the workforce as much.
Don't want to end on a dark, sad note. So without being dystopic or morose, what's going to happen in the next decade or two? And end on a positive note, Alex.
Well, on a positive note, I can tell you that maybe my own personal experience. Obviously, I do that. I've been doing this now for 25 years. I could not think about anything else. It's very special to take care of these patients. If you go to pediatric, obviously you like children, I love children, but being able to help these patients with certain types of congenital heart disease have a real chance of living a really great life. And to be part of that, when you meet them, the families, the emotions that are in the room, and then actually being able to help these patients, I believe it's very special. So I could only encourage the young generation to see that aspect of your work. It's very fulfilling. I personally feel very honored to take care of these patients.
Beautiful. Thank you. Thank you for ending on that positive note.
Yeah, Alex,
thank you.
Fantastic.
Yes.
Thank you.
Thanks, you both.
Well, and thank you for watching here at Top Med Talk. You can always check us out on social media. We are on LinkedIn. Check us out. If you haven't subscribed, you can go on our YouTube channel and subscribe there. And let us know if you like what you're hearing. Give us a thumbs up. You can also subscribe on Apple Podcasts. Thanks so much for listening, everyone. Cheers.
Top Med Talk. Thanks for downloading Top Med Talk. Don't forget to subscribe. Check us out on YouTube and, of course, on social media. We're on Instagram, Facebook, and X. Also, it's important to remember that Top Med Talk is the broadcasting arm of EBPOM, evidence-based perioperative medicine. We'd love you to find out more about that, and the way to do that is ebpom.org. Check out our website and find out about some of the incredible conferences we're going to be arranging across the year. ebpom.org.